Please welcome Linda Mikitish. She is with St. Luke's Health System, and she's going to be talking about medication adherence and working with CHWs. Linda is a transitional care nurse who works with heart and lung patients as they transition from the hospital to the home. She comes alongside patients to help them become better self-managers of chronic conditions such as heart failure, heart disease, COPD, and diabetes. Linda believes that when people feel supported, heard, and encouraged, they can be more successful in improving their health. Linda has worked with St. Luke's Meridian Medical Center as a cardiac nurse and heart and stroke patient educator prior to landing her current role with cardiac and pulmonary rehab. Linda is a certified heart failure nurse, guided care nurse, and has twice been recognized by St. Luke's with the Nursing Excellence Award. She holds a Bachelor of Science in Health Science from Boise State University and a Bachelor of Science in Nursing from Idaho State University. Welcome, Linda.
Thank you. Well, thanks for having me. This is, I don't know if it's an exciting topic. It's one that I have a lot of passion about. And I'm going to try to behave and not rove too much or pull off my lead that I have, but I'm a pretty hyper person. So bear with me through that. A little bit about the care transition program and what that intervention looks like and why I feel so strongly about this is it began as a nurse navigator pilot a little over 6 years ago, and it was specifically for heart failure patients. I was going in patients' homes after I met them in the hospital within a few days of them getting home from the hospital, and I spent about a couple of hours with them for that visit. I go to doctor appointments with them. Either I see them in person or talk to them by phone for about a month to a month and a half. If I choose to bring someone onto the guided care program, that's the guided care nursing, that's a Johns Hopkins certification program. Then they stay on long term with me until either they pass away or we transition to hospice or they choose to go off service. But there are just some people we can't connect to all the resources they need, and they need more care support. So medication management is a huge piece of this. We could have a whole symposium about just medication management and breakout groups on that. We're going to focus on medication adherence today. I do want to get an idea of who I have out here in the audience, and like with a show of hands, who is a community health worker? Okay. And I know I have some community paramedics. I got to meet Travis for the first time. Brandon and Mark are back there. I've met some of the pharmacy staff from here. So I have some pharmacists, nurses, okay, physicians, other healthcare providers. Me. Okay, excellent. So that'll kind of help us in our discussion. I do want to tailor this to what you need. So if we need to change something up, maybe you know about it already and we can just move past it more quickly. But when we do go out in the home, and that is the beauty of being a community paramedic, a community health worker, a care transition nurse, a home health nurse, to sit down and be present with a patient and talk to them about their medications, we see all kinds of different ways that patients manage or not manage their medications so well. And some of those methods that they use make it difficult to adhere to their therapies too. We want to see this really nice organized cabinet and somebody who's setting up Medi-Sets, but maybe they're going to be more down here, and they might have their medications organized in baskets even in this setting. Or up in here where they're using bags and they have their different bags are designated for things. So I know I have a lot of learning objectives that I'm hoping that we're going to get through, but I do want us to understand why this is an important topic and then go and look at the primary causes that have been identified by research. We're going to go into these couple of tools, one of them based on these three primary causes, but another one that goes a little bit deeper into some barriers. I want to look at some strategies that we can use really to help people better understand the purpose and importance of their medication. We're going to go a little bit into motivational interviewing with this decisional balance and developing some discrepancy to help them maybe weigh side effects versus importance. And then the financial burden of medications is a huge piece of this. So the latter part of the presentation will relate to that. So when I read these and I was looking at putting this presentation together, pulling some things from some previous presentations and just reading some articles to refresh myself, some of this really surprised me. One, that in developed countries, 50% of chronic disease patients don't adhere to their medications as prescribed. And then the cost down here, this, get my little pointer to work, this $300 billion in the United States of avoidable costs. I mean, it's pretty astounding. But really what affects us when we're one-to-one is the decreased quality of life, the poorly managed symptoms, sometimes death, related to that. And when you're working with somebody like a diabetic or a coronary artery disease patient, a COPD patient, this can mean that they may have conditions that develop. Maybe the diabetic loses their sight. Maybe they lose a limb because they didn't have well-controlled blood sugars. We have a really important role in trying to, one, control costs, but also to improve quality of life. So 3 primary causes that research says, and I know that this is very simplified, but just knowledge deficits related to the purpose and importance, the concerns about side effects, which is huge, and then the financial burden. So Merck puts out this little survey, and I put a link on here. You could go on this with a patient, put in the name of a medication, have them click through the boxes, submit it. The next screen takes you to where you can click on the healthcare provider. You open it up, and it gives you a score on this. So I did this myself, and this would be if I was hypothetically prescribed lisinopril, what I would say about it, where I would I completely agree to disagree completely, and I agree somewhat that the medication is necessary, and then I just disagree somewhat about the concern about harm, that it's going to do more harm than good. And so I come up with 11 points, which puts me at a high likelihood to not adhere to this. This is a good tool. We had Merck deliver to us when we started our program just a stack of the paper ones, and we used them with people as we had a lot of new prescriptions. But you can use this with their other prescription medications too. The Meriski medication adherence scale is pretty commonly used. It was quite a privilege to sit down with a community health worker in a home of one of my patients. She was from Blue Cross of Idaho, and she was doing an intake. And some of these were embedded in her questionnaire. And I thought, can you guys see these from the back? I thought maybe we could just talk about and point out some of the things that might be barriers or challenges for the patients that this scale is trying to get at. So, for instance, do you sometimes forget to take your medications? What might be at play there? Okay?
Trying to save money.
Okay, trying to save money can be a big part of it, yes. And then people sometimes miss their medications for reasons other than forgetting, and just asking if there were any other days when they didn't take them. Did you ever cut back at your medications? And that can be because of cost, but because without telling your doctor that it made you feel worse. So this is pretty common where they'll stop, and that's something we can encourage them to talk with their doctor about. Leaving home without their medications. What other things are coming into play up here? I thought about schedule. Anything else?
When they leave home without them?
Yeah, or any of the others. So like taking your medication every day is a real inconvenience for some people. Do you ever feel hassled about sticking to your treatment plan? Yeah, they're overwhelmed maybe. So when I read through this, I just started listing a bunch of things. Maybe they don't have a medication system that works. It might be their lifestyle. It's their schedule. They're annoyed with it. It's frustrating to be chronically sick. It might be about their culture. There's this one, let's see, where is it? About where I was thinking about culture. Like you feel like your symptoms are under control. Do you sometimes stop taking your medication? That is very much an American culture thing, where we take a medication for a short amount of time. I get prescribed an antibiotic, I get well, I don't take it anymore. I have a cold, I take something. I have a virus, I take something. But to be chronically ill and have to take something long term, and maybe on days that you feel good, they may think maybe I don't need that medication. So and then there's other cultural barriers too to that, and of course education. And I put honesty on here because unless this person trusts you, they are just going to say whatever they think you want to hear to these questions, and then it's not even a valid tool for us. So the community health worker, person who sits down one-to-one with the patient, has the ability to build a relationship and really get honest answers. Yes?
Did you ever find any correlation between the Adherence and maybe up to some of these questions, and they had not been screened for depression, maybe secondary to the chronic health issues or for anxiety? Did you ever find it?
Yes, so depression is a huge piece of it, and that's something that we need to be aware of, and maybe embedded in your tools might be a PHQ-2 where you are asking 2 depression screening questions, and if either one of those is positive, then that takes you to a PHQ-9, or it triggers you to notify the primary care physician that that's positive so they can complete the screening. But yes, depression is a big part of it. And for chronic disease patients, we know that is something that's common amongst them. So thanks for bringing that up, Mark. Was there anything else that you thought of?
Sometimes people are dependent on caregivers to give them their medication, so they're not even in control of whether.
Right. Yeah, for instance, I had a patient this last week. He ran out of his water pill. He doesn't drive. He's completely dependent on his family caregivers. There was a crisis with one of the other family caregivers, and this man's diuretic sat at the pharmacy. He was up 10 pounds of weight and short of breath, and we were fortunate we could retrieve that without him having to be hospitalized. So it's definitely true. Yeah, they can be dependent on somebody else. So when we talk about knowledge and their understanding of it, it's important we can be able to assess knowledge deficits. And I really like asking people's permission to do something, and this is a common question. It's like, we have some time to talk about your medications. Is it okay if we talk about the purpose of each? And I'll use these open-ended questions by an imperative statement. I'm meaning like an understood you in front of that, where I'm saying, tell me, show me. I'm not giving them any yes or no opportunities. And we're just going one by one through things. Which of the medications do you take for diabetes? And they can pull those out, and maybe they pull in medications that are cardiac medications into that group and accuse me, and they really don't understand what these medications are for. But I'm looking for anything that tells me they have a knowledge deficit, and then I want to find a way to address it. So you can help that patient make a list of questions for their provider. Maybe you're going to make a phone call while you're in the home with them to the provider if it's just one question about one medication. If they're a little more technologically savvy and they're using a patient portal or something like St. Luke's has with Epic, what's called MyChart, you can help them get in there and write those questions in that email format to their provider so the provider can answer back. It's a great way to do it because it doesn't like clog up that queue within that office, within that clinic. So you may offer to attend the next appointment with the patient if you've made an appointment with them for them to go in and talk. I just pushed my button back there. I gotta be careful.
And it would be nice if even from the very beginning with the prescription that is prescribed, that on the prescription it tells the patient what it's used for.
It would be helpful.
In a wonderful world.
Yes. I want to make one, just put this out there, is that there are medications that are prescribed not for the main purpose of this. So if you're tempted or a family member has gone in and looked at something, I'm going to use a heart failure patient for an example. Guideline medication, guideline therapy for a heart failure patient can include 3 to 4 medications that affect blood pressure. And if you Google those, blood pressure will come up as the reason or the purpose for that medication. But heart failure patients typically have low blood pressure. So they may stop taking a medication because they say, I don't know why my doctor prescribed me 3 or 4 blood pressure medications when my blood pressure is so low, so I stopped that, not knowing that one of them is affecting the hormonal system, which is driving the heart to work harder, taking down the preload and afterload of the heart, helping the heart squeeze and relax more rhythmically. There's a purpose for those. So you have to be cautious with that. Bedside nurses will sometimes be required to type in a purpose for a medication, and they might do something as well, the same, put in something general, and that might be something very specific for that patient. So really talking with the provider to understand that, and the pharmacist may not know that either. I sat with a pharmacist doing some education with the patient, and they used that same terminology. This medication helps control your blood pressure. And because I was there, I was able to just say, and for you, you take it because it helps your heart squeeze and relax more rhythmically. So just be cautious with it. And then you're going to consider the pharmacist, though, as a resource. And you're going to consider home health nursing. Because a home health nurse can come in and piecemeal this at a slower pace for that patient. What would qualify a patient for home health? Homebound. And what does homebound status mean, like by Medicare? So it is a little bit subjective. For some agencies, they'll be very black and white about it, but it really means it's a taxing effort to leave the home. They can go out to church. They can go out to family events. So a family member could take them shopping. If they can independently go and do their own shopping, they could go to a movie. They may be traveling somewhere. They're not going to be considered homebound. But so home health is very underutilized in our community. And you can ask a primary care provider for a home health referral for someone for medication management. So what other ideas might you have to help a patient understand what is the importance or what is the purpose of a particular medication? Things that you may have tried that we didn't mention. Have we been pretty comprehensive and covered the things that you've thought of? Because this really dovetails into concerns about side effects. If we have developed with this patient the importance, then maybe the side effects aren't going to weigh so heavy on this. But we can provide them some printed material, but we need to go to reputable sources and be really cautious about doing that. Most of us who work in a healthcare system have a particular education format that's provided to us, and our system really wants us to use that. National Institute of Health, Medline Plus, up to date. The pharmaceutical's own website is going to provide you accurate information. And then asking them to just take something to the pharmacist where they can ask them about that the side effects of that medication, because the pharmacist can help them see that maybe this is a common side effect and their doctor can do something about that with them, or the pharmacist can make a suggestion about something they might do or how they take that medication. For instance, potassium chloride can really knock the gut out, and if you take it with a meal, it's much better. And they can point out maybe that small writing on the side of the bottle that person can't really read. So you can use this, and then always, of course, encouraging the discussion with the provider.
We find that a lot of our patients that may come through for our services that we aren't the primary care, or because we see anyone in our community, but a lot of times if they've got another physician outside of our system, it may not be a generic that they've prescribed, even though there is one available.
Yes.
And they didn't ever tell the doc, I am on very limited income. So they may listen to the whole conversation about the importance of the medication, but they have no intention of filling it because somebody's told them it's $500.
Yes, when we get into talking about the cost of medications, and that's a good point to bring up, we really want to point that out because we do have a role in contacting that prescriber and say, hey, there's a cheaper option for this patient. Could we consider this? Or maybe there is a medical reason why that patient needs to be on that particular medication. And I'm going to talk to you a little bit about tier exceptions and those forms that you can use to try to kind of buy down the price of that medication. So we're going to move a little into this motivational interviewing piece of things and talk about decisional balance, what that means, and developing discrepancies. And the first thing we need to be is really good listeners. And we're listening in this whole conversation from the beginning to where we are at this point. And what are they saying to me? I've heard them say, I want to do everything I can to get better. Managing my diabetes is the most important thing to me right now. I'm afraid of getting sicker. The side effects are driving me crazy. I can't take that medication. It's making me nauseous. This medication makes me dizzy. Let's hear some things that you've heard from patients about medications. Yeah, oh yeah, warfarin. We know what we're talking about here. Yes. That's something. So that fear of that medication is huge.
It's too big to swallow.
Too big to swallow. Anything else? I know you'll think of these as we go into this next section, which is DEERS. Is anyone familiar with this? Developing discrepancy, expressing empathy, amplifying ambivalence. We're going to go to when we go to the next screen, it'll be about rolling with resistance and supporting self-efficacy. So there's no sequential order that you use this in. Primarily go to expressing empathy first. This is not the same as sympathy. So if somebody says, my medication cost me $500, and we say, oh, you poor thing, that's pity, not empathy. It's really challenging for you right now to afford a medication that costs $500. Just say it. I'm not judging them. It's kind of a flat statement. it's objective, and those are the kind of expressions that we would want to deliver to the things that they might say, I want to do everything I can to get healthier. Your health is really important to you. Empathy is fabulous. You're not solving any problems. You're just reflecting whatever they're saying. And if it says, this medication makes me itch, it feels really bad that you have to take a medication that causes you to be so itchy. Just saying the same thing that they're saying back to them. The reflecting without criticism, blaming, or judging. And you're going to hear blaming, judging in other people's voices more now that you think about this, because when a doctor will start talking to a patient, why didn't you take that? You know, I told you that you were supposed to take that 2 times a day. Why aren't you doing what I told you to? I mean, you hear this accusing voice, and that just shuts people down. So developing discrepancy and amplifying ambivalence are very similar. And this is normal in all of us. This isn't anything that we're trying to say, oh, I caught them. They are saying 2 different things. They're telling me that they can't take their medications, and on the other hand, they're saying this. That's not the point at all. So developing discrepancy, I might bring out the scale. This could be 2 types of scales. It might be the 1 through 10. Say, how important is it to you on a scale of 1 to 10, 1 little to no importance, 10 very important, to manage your diabetes? And they're like, oh my gosh, it's a 10. So you showed me that you take metformin, glipizide, and you have some insulin. How important is it to you on a scale of 1 to 10 to take these medications? 3. So I have a discrepancy where I can say, on one hand, it's really important for you to manage your diabetes. And on the other hand, you're really challenged by taking these medications. Can we talk about some ideas or brainstorm some ideas on how you can manage your diabetes in a way that works for you? I don't like to take metformin, it upsets my stomach. Well, guess what? The short-acting metformin often does upset stomach. The long-acting tends to do a little bit better. Maybe we can change that prescription, talk with the provider about that. There's things that can be done to help them resolve that. Maybe they don't want to take so much insulin. Maybe they'd be happy to go to a diabetes educator and learn more about what they can do. But you can find something that brings them in. And what we're really working on here is supporting self-efficacy, where we're making them feel confident. We're trying to increase their self-confidence in management, and we want to move them towards a more positive and realistic view, not something that they feel is being told to them that they have to do, but something they embrace and want to do. When we amplify ambivalence, the science, the communication theory behind this is that we are often of 2 minds. And in the same conversation, I might say conflicting things. We even do this in politics. Person says one thing, this conflicts with what they just said. By just stating them out loud, it puts them out in the open. And it's interesting how that theory works, because they're more likely to move to an action stage of change if you bring these out into the open. Rolling with resistance is super, super important. All of us know who work directly with patients that we get resistance on certain things. They don't want to make diet changes. They're being told what to do. They don't want to have this regimen for their medications. They're resisting. So you need to be looking for these, arguing, interrupting, denying, ignoring. If you have more things on that scale in the negative than the positive, you are not going to move forward. You cannot rationalize with this person. It's not a good place to be. It's better to say, this is a really troubling topic for you. Is it okay if we talk about it when we next meet? Take it off the table completely, or you might just bring out the resistance. I have a super resistant patient. He hates all his medications. He's very susceptible to side effects. He has some mental illness problems. And he says, I want to live longer. I can't take these medications. And so I just keep rolling with what he's saying. I just say it back to him. And then we got to a point in one conversation where I just said, it's really hard for you. You can't take the medications that could help you live longer. And he's like, what? I'm not taking the medications that can help me live longer? And it was a total changing point for him, where he said, I need to talk with the doctor about that. I told him I wouldn't take that, but I think I want to try it now. So this does really work. Any questions about this or anything you want to talk more about in it? Mark? Yes, so you can move that into the next stage where you've done the importance. And maybe they say, okay, it's 5 of 10 important to me to take my diabetes medications. And I say, what would it take for you to give me a 7 or to give me a higher number? And they'll say, well, if I didn't have to give myself so many shots, then I would move to a 7. What could make a difference? How could you get to a place where you wouldn't have to take so many shots? Well, if I changed my diet maybe, and I didn't just eat a bagel for breakfast, but I ate an egg and some fruit like my doctor told me, I probably wouldn't need as much insulin. And then it's like, would you like to set a goal for that in the next week? How many breakfasts do you think you could try where you combined a good protein and a carbohydrate? And so we come up with some kind of a plan that's very specific. What days are you going to do this? I'm going to try it on Monday, Wednesday, and Friday, or whatever days work for them. Maybe they need to go shopping or make a list, and you help them make that shopping list. And then we get specific days. I get them to state it back to me. And then have them give me a confidence level. So now I'm moving from the scale of importance to the scale of confidence. On a scale of 1 to 10, 1 being little to no confidence, 10 being very confident. How confident are you that you can eat this breakfast 3 times a week in the next week? If they give me a 7, we're golden. If they give me any number lower than that, they're not likely to succeed. So you're always looking for a 7 in all of the scaling. And so then again, I'm going to ask them, what would it take for you to give me a higher number? Well, if I only had to do it twice, I'd probably say it's an 8. Done. We change the action plan and we move forward on it. And then you can do that with medications too. I had a particular patient really struggling with like just remembering to take them. And so I asked her, I said, could I give you a suggestion of what another patient of mine has found success with? And it was about setting an alarm on her phone to remind her, to wake her up. And she said, well, I don't know, that probably wouldn't work for me because I'd probably just turn it off. But if I put my phone over by my television, I'd have to get up out of bed and I'd have to go over there to my phone. And if my medications were next to my phone, it would trigger me to remember to take my medications. It worked out great. And she was super confident in doing that. And that woman is amazing now, like clockwork. She's taken her medications. She's a kidney transplant patient. She's got tons of meds that she takes. Type 1 diabetic, heart failure. Yeah, very sick lady, but she's really embracing being responsible for her health care. Anything else?
You follow up next week?
Yes. Mm-hmm. Yes. So that follow-up is super important. I have a couple of different action plans that I use. One of them is maybe for somebody who's at a little bit of higher level, higher health literacy, and it has some check boxes down below where they can check off some things through the week and like make some notes, and then we can talk about those things. And another one is more simplified where it has pictures up at the top. It has like medications. It's like something I can do to improve my food, my diet, and so it's a little more of a pictogram type of thing. But yes, and we follow up the next week. Was it a good goal? So the idea is not, we want to set them up for success. And so you want to point out everything, the best things. What was your best experience that you had with your goal this week? Instead of finding out, how did you do? Did you fail? What % did you get at? You know, I want to find out what the best experience was, and I want to build on their success. And it might be, well, that didn't really work for me. I had to take that medication later in the day, and so I shifted things around. And so I acknowledge their problem solving. Hey, you didn't feel like you had to stick to this. You were inventive. You didn't throw it totally out. You changed it. And then do they want to keep that the way it is? Do they want to toss it out and try something new? Do we want to change it up? So we're trying to build on those same goals and move forward. So by the time we're maybe 4 weeks into it, instead of 1 to 2 action plans, we might be at 4 to 6. But that's a great question. Yes, a follow-up, and we can do that by phone, or we can do that by meeting them in person at a doctor appointment. Hey, anything else? All right, one more thing about motivational interviewing. It's a very huge topic, and I know there's a motivational interviewing workshop going on right now, or another one of these breakouts going on. If you get an opportunity, Brandon, I think we did a motivational interviewing workshop like maybe 5 years ago. Yeah, so to go and be immersed in it is what's really valuable. So if you can get into workshops where you're going to do 2 to 3 days straight, or you're going to go an 8-hour day, come back in a week and do another 8-hour day and another 8-hour day where you're practicing it and you're being accountable throughout the process to other people in the class. It's something that you do repeatedly because you're going to pick up tools every time to put into your practice. It isn't something that we just like, oh, we learned something about motivational interviewing and now I can do it well. If you can pick up a few tools as you go, you'll have a better practice. All right, the financial burden of things. So this next section, I want to go into a little bit into insurance coverage and particularly into Medicare. But I want to know, are most of the patients that you work with Medicare patients? Do they have are they commercial payers, uninsured, combination? Combination? All right. I think understanding Medicare, look at how much time we have. So I think we have about 30 minutes, which is good because I have a little clip about Medicare. There's a lot of misunderstanding about it, like the gap, what that means, which is the donut hole. How do we explain this to patients? How do we understand deductibles? What Medicare Extra Help is, a little bit about SHIBA, and then the patient assistance programs. And I'm going to show you one that or a couple that I particularly like and use quite frequently. So let's see if I can get this to load up for us. Awesome. Amazing. How's your understanding of
when considering Medicare Part D
Okay, here we go.
prescription drug coverage, you may have heard of the Part D coverage gap, also known as the donut hole. What is the coverage gap? Could it affect my Medicare Part D costs? The best way to answer those questions is to look at the coverage offered by Part D during the different stages of Part D coverage.
Okay.
This will help you know what to expect during each stage of coverage. There are 4 Medicare Part D coverage stages that can affect your prescription drug costs. The first is the annual deductible stage, which applies if your plan requires you to pay an annual deductible. If so, you must pay the full cost of your prescription drugs until you have met your deductible amount. After that, your...
Sorry.
When considering Medicare Part D prescription drug coverage, you may have heard of the Part D coverage gap, also known as the donut hole. What is the coverage gap? Could it affect my Medicare Part D costs? The best way to answer those questions is to look at the coverage offered by Part D plans during the different stages of Part D coverage. This will help you know what to expect during each stage of coverage. There are 4 Medicare Part D coverage stages that can affect your prescription drug costs. The first is the annual deductible stage, which applies if your plan requires you to pay an annual deductible. If so, you must pay the full cost of your prescription drugs until you have met your deductible amount. After that, your plan begins to share the cost of your covered drugs. The second stage of coverage is the initial coverage stage. If your plan requires you to pay a deductible, the initial coverage stage begins after your deductible is met. If your plan does not require you to pay a deductible, then the initial coverage stage begins the first day your plan takes effect. The third coverage stage is the coverage gap, also known as the donut hole. You will reach the coverage gap once you have spent a certain amount on your covered prescription drugs. This amount is determined by Medicare and can change each year. Keep in mind that if you receive extra help from Medicare, you will not have a coverage gap, no matter how much you spent on your covered prescription drugs. During the coverage gap, you will be responsible for covering more of your prescription drug costs, unless you enroll in a plan that includes coverage in the coverage gap. The amount you pay for covered drugs can be a fixed dollar amount, called a copayment, or a percentage of the drug cost, called coinsurance. When considering a Part D plan, always look for copayments and coinsurance costs during each stage of coverage, especially during the coverage gap. The fourth and last stage of Medicare Part D coverage is called the catastrophic coverage stage. You reach this stage after you have spent a certain amount on your covered prescription drugs while in the coverage gap. Again, this amount is determined by Medicare. You will remain in the catastrophic coverage stage until the plan year ends, when your out-of-pocket cost for covered drugs will generally be lower. Not everyone covered by a Part D plan will reach the coverage gap. But if you take several prescriptions and are likely to reach the coverage gap, you may want to consider a Part D plan that offers additional cost sharing in the coverage gap. Not all Part D plans offer this extra coverage, which is why it is important to review all coverage options before you enroll to get the most value from your plan. Keep watching for more Medicare Part D information and be sure to visit silverscript.com to learn more about the...
Okay, so clear as mud. So the reason this is important is because this is very messy and it's very hard for people to understand, and we can bring some clarity to it or find resources to bring clarity. This is just an example of someone's insurance. There are some very specific things about the Medicare gap and about how this is calculated, or even deductibles. So deductibles for Medicare, are not paid on Tier 1 and Tier 2 drugs, which are generic. They start on Tier 3 and higher drugs. We know this happens when somebody goes into the pharmacy, they have a brand new medication, it's brand name, it's new, and they say, this medication is going to cost me $300 per month. That's not really accurate. What we need to do is find out what tier is that drug. A part of that is their deductible. And until they meet, for this person, a $405 deductible, they will keep paying a higher amount on that drug, and then it's going to drop down to a lower cost. So it's important for us to be able to kind of navigate through insurance resources. Once they hit that gap, that's a total running cost of medications, both what the patient is paying and what insurance is putting into it. And insurance companies set that individually. It's different for every company. When they hit that, then that patient is going to pay almost full cost or a large portion of the cost of that medication until they hit the next level where they go into the catastrophic, and then their medications are going to be super cheap. And so they really don't understand, why is this medication now $15 when a month ago it was $180 and 4 months ago it was $43? So I'm going to use an example here of the Dulera inhaler, which this is a tiering. What I've done is I've taken the name of the patient's insurance off of their insurance card. I Google that and I put in 2018 formulary. You can do this for Medicaid too, because Medicaid, all the insurance companies, Medicaid, they change their formulary every year. So you have to go in at the beginning of the year. Something that was covered in 2017 may not be covered this year. So my patient's prescribed Dulera. I go in and I see this is a Tier 4 drug. This means they're going to be paying, when they first start getting this medication, they're going to be paying their deductible plus that tier cost until they meet their deductible. And then the month that they meet the deductible, it's going to go down to the cost of that Tier 4 drug. So I need to be able to tell them what those costs are. And this is the stages, what you pay during the stages. This patient is in this option 2 HMO. And so the first thing I find is they're at a non-preferred retail pharmacy. So I'm going to move them to a preferred retail pharmacy. It's a Tier 4 drug. It had a $100 copay. They're going to move to a $90 copay. I'm going to ask their provider to move them to a Tier 3 drug. I'm going to say, would one of the other inhalers work for them just as well? Can I get their cost to $37 a month? And then I want to know from that patient, is that okay? If this patient, in this case, has a $200 deductible, they're going to get done with that a lot quicker. If they had this True Blue HMO or the True Blue option 1, they'd have a $0 deductible. So, and then they would just be paying this $37. maybe their doctor tells me they can't be on another drug, on one of the other inhalers, because they have tried the other ones and they kept getting repeatedly hospitalized till we started Dulera, and now they're not getting hospitalized, their COPD is better managed. So then I'm going to do this, try to go for this tier exception with the insurance company, and we're going to look at what that's like. But here's the things you can do. Ask for the less expensive option. Try to move the tier to a lower tier. Ensure that they're using the preferred pharmacy. Super important. Maybe they have to drive another mile, or maybe a family member will help them with that. But whatever it might be, going to the preferred pharmacy is going to make a difference. Consider changing plans during open enrollment. So that's going to be both for somebody who has a commercial plan or has a Medicare plan. And then there's insurance brokers, advisors that can help. And then when we talk about Sheba, I'll tell you kind of how that works. I want to make a plan for the Medicare gap because I want them to realize that this medication is $37 right now. But behind the scenes, that insurance company is calculating, and that more expensive drug is going to put them into that gap quicker. If they have, like a lot of COPD patients have 3 inhalers, if those are retailing or what the insurance company is calculating at $300 to $400 a piece on those, they're going to be in the gap quick. They're going to be in the donut hole. What are we going to do when they go in the donut hole? And that's where patient financial assistance comes in. A lot of insurance companies have a calculator that you can use where you can go in, put in the name of the drug, and it will tell you what that drug will cost for the year. So this is about what you do with a budget. So maybe it's going to be $900 for the year. It's calculating what it's going to cost them in the coverage gap and in the catastrophic cap of it. You can divide that out over 12 months and say, can we figure out a way that you set this money aside so you're ready when you go into the donut hole? Is that amount of money okay for them each month? There's a new inhaler out called a Trelegy. It covers 3 different inhalers. Maybe we can move them to that one inhaler and take away these 3 tier 3s, and maybe Trelegy is a tier 4, but it's going to cost them less. So what I'll do for providers is either I'm sitting while I'm in the office visit with them, I'm Googling the formulary so that I can give them an idea. They're talking about prescribing something new. And I'll say, hey, Dr. So-and-so, that's a tier 4 drug. Would any of these tier 3 drugs work? And I show them what they might choose instead. And then I'll print this tier exception form for them. And what I'm going to ask is, my drug plan charges a higher copay for the drug my prescriber prescribed than it charges for another drug that treats my condition, and I want to pay the lower copayment. I get that checked. I have the doctor put their documentation on it and their signature on it, and they fax it, and then you follow up because those can come into the fax abyss in that office, and you need to call and double check to make sure that this happened. And if it came back and they kicked it back for some reason, if they didn't have the right documentation, whatever it might be, you can facilitate this happening. This is very successful. If you're asking them to move more than a tier, not so successful. The insurance companies typically don't like to do that. They don't like to move a brand name drug to a generic drug. So if it's a tier 3, tier 4, they don't want to move it to a tier 1, tier 2. But it's worth asking and trying to get some relief for these patients.
The doctors you work with, do they use the same meds over and over? Each patient with heart failure gets this bucket of meds, the same medications for each patient?
With heart failure, it's more common, yes. Heart failure medications most of them have been around a long time. There's a couple of new ones out on the market, and in order for a patient to qualify for that, they have to be tolerating other heart failure medications, and blood pressure alone takes away the ability for a lot of patients to try the new medications. So those older heart failure medications, they're very cheap. Where a heart failure patient might get into trouble is if they also have atrial fibrillation. They've been taking warfarin, which some patients will say is rat poison, and there's a good place where a pharmacist can help them understand the difference between that. But warfarin's very cheap, $4 a month. Eliquis, $200 to $300 a month. Or Xarelto, same thing. But sometimes those will be, one will be a tier 3 and one will be a tier 4, and you can move them. And then there's some really good patient assistance for new drugs, which we're going to talk about.
I have one thing too.
Sure.
So I also want to point out too that some insurance companies, if you decide to go through their mail order, they will let you do a payment plan for, say you get a 3-month supply. They don't have you pay the upfront all at once. They'll actually do like a payment plan.
So like a budget.
Yeah. So it does allow them to budget a little.
And then some of the mail order does save them money too. It's cheaper.
Yeah, some will even do a 0 copay if it's a tier 1. Everything's a 0 copay if they do mail order.
Yeah, thanks for pointing that out. Medicare Extra Help. Anyone familiar with this program? Yeah. So it's little known, and more people qualify for it who are on either disability and have Medicare, or they are on Social Security. So it's going to be almost $5,000 a year. I always think if I can save somebody some on money on medication, maybe then they'll buy healthier food. They will be able to afford the gas to get to their doctor appointments. Maybe they'll have more fun and go out and do things that they enjoy. So these are the qualifications for 2018. This is the full Extra Help. It's going to cover their, go back to this. So their monthly premium, their Medicare premium for their Medicare Part D, their annual deductibles, pays it, and then their prescription copays, which takes the cost just way down. So if they qualify for this, the headache that, oh my gosh, my medication cost me $500 goes away. It's worth checking into. Some people will say, oh, I own my own home. That doesn't matter. It's not counted in this in resources. So home, vehicles, and the things that are listed down here not counted. Here's a link for you. So I know that my slides were posted, and you should have access to those. I did update them a little bit, and I'll get those to, can I get those to you, Nicole, that you could put an updated ones? But for the most part, the links are throughout here, and you can just click on them. Are we familiar with Sheba? Sheba is fabulous. In our department, we ask their advisors to come during open enrollment, and we set specific days for them to be there. And a month in advance, we're signing patients up to take those slots and meet with a Sheba advisor. They can meet with them throughout the year. Sheba advisor can help them apply for Medicare Extra Help, help them find financial assistance, but choosing that Medicare plan that best fits them. And then, of course, within the exchange, the healthcare exchange, there's healthcare advisors within that too. So assistance programs are out there, and I did want to bring up low-cost clinics. In our area, it would be Genesis, Family Medicine Residency, Terry Riley. And sometimes a patient needs to take primary care with one of these clinics to get sliding scale care and sliding scale medicine. Maybe it's just for a short period of time. Some of our St. Luke's providers are wanting to keep these patients in, and as care transition nurses, we're saying they can't financially afford this, and if I can link them to a medication resource along with their primary care physician, that's where we want them to be. Terry Riley has a wonderful grant program. They can meet with a social worker there. They can connect them to other resources. I can't say enough about the programs there. Anyone here at Family Medicine Residency, Terry Riley, Genesis? I know there's a clinic that's out in Caldwell, too, that one of my other nurses has been working with. But it's good to just research, know where they are, and know how you can tie a patient in to get some help. And maybe it's just temporary for a period of time until you can figure out other things or other resources for them.
Our group of clinics down in southern Idaho are also hooked into the 340B.
Yes. So pharmaceutical assistance programs, I want to talk about the online resources that I like. There's a lot of them out there. We like these discount cards too. FamilyWise, GoodRx, that's just 2 of them. There's tons of them out there. Sometimes I'll print 10 different cards for a patient and say, find out which one works for you. And then keep that card. They can just reuse it over and over. It's going to buy down the cost of that medication a little bit. FamilyWise, I have their app on my phone. One of my other nurses likes GoodRx better, but I can be sitting at a doctor's office and put the name of that medication in and tell them which pharmacy has it the cheapest. So it's a pretty nice resource. But
The things that we've seen that is unfortunate, sometimes clients get one of those cards or multiple cards, which is great, but they think they've got their Part D cards. And they find out, no, that's just for that particular.
yes, and they're mostly on generic drugs, buying them down, not so much your name brand drugs. So needymeds.org just happens to be my favorite. There are a lot of others out there that you can use, but this is kind of a one-stop shop. And do we have time? Maybe have some time. I'm going to come back to it and show you it if we have a little bit of time here at the end, where you go in, you put in the name of the drug, you do a drug search on it, you go down to the bottom, you can print a coupon for them to get maybe the first month as a trial free. If they have a commercial plan, there's often a card that will buy down that copay on it. So maybe their copay is then $10. That's what Eliquis is, a $10 copay for a commercial. And then there's a link to get an application for the pharmaceuticals program for assistance. Many people they don't think they're going to qualify, but they do. And even if they have Part D, they can qualify for this by spending X amount of dollars, whatever that pharmaceutical company says. Oftentimes it's 3% of their income, and it's the people and most of the time it's the people in their family. So if it's a couple, it's the medication cost of both of those people, what they're paying at the pharmacy. They go to their pharmacy, they get a printout. If that is greater than 3%, we put that application in. There's a part that the patient fills out, a part that the provider fills out. The patient has to provide the documentation from the pharmacy, proof of income, and then we send those in. They need to be faxed, should be faxed through the doctor's office, and then follow up on them. You always have to follow up because something might happen, like they couldn't read the NPI number. The doctor's signature wasn't clear. They were missing one number off of the patient's birth date, whatever it might be, that they kick it back. But usually we can get this accomplished within 30 days. So if we get them a free trial card, and don't think that those free trial cards don't work for Medicare patients. There's something on the back of them that talks about federal programs. That's just saying you can't bill that federal program for that cost of that medication. So I can't bill Medicare for it. It's strictly being paid out of from the pharmaceutical company. There's a 1-800 number on there. If a pharmacist is concerned about running that card, just call the number on the card and let the people at that company talk to you about it, because they can use it. So needymeds.org also has a screen that you can open. It says patient resources. You open that up, it's huge. It's got transportation, all kinds of things in there. The section that I really like is about disease-specific or diagnostic-specific programs. So maybe I want my patient needs a new insulin pump. Who knew? Insulin pumps are like $8,000. And their insurance company, they have a 60-40 split. So they're going to pay 40%. The insurance company is going to pay 60%, but this person is on Social Security and doesn't have the money to do that. Well, you go into diabetes, you search in there, you drop down. There's a company that is refurbishing pumps and can provide them to the patient for free. And there's other grants and programs that are listed within there that are really excellent. So this is a great resource for you. RX Outreach is going to be cheaper than even like your $4 list at Walmart. It is generic drugs, but these are really good numbers here. So if you look at these, an individual 36,000 and going down on the limits for income, there's an application that you fill. We have this right in Epic, so our providers can send a prescription right into them, and this is a mail order pharmacy. So things like digoxin, which might be $60, might cost them $20 for a 90-day supply. You know, it's cheap, a lot cheaper. So it's worth it to go and find, maybe it's even just 1 or 2 medications that patient takes that's more expensive. Don't run it on their insurance. Try to get it through outreach at a cheaper price. This is just my note about Medicare Part D, and the reason I bring this up again is just we've had instances where Patients go with their card to the pharmacy. The pharmacy says, you can't use that because you have Medicare Part D. And the patient goes, oh, and they pay for the medication. And then it's very difficult to get that refunded and then use the card. So I'm always educating the patients. Just ask them to run the card or if they're worried about running the card, to call the number on the back of the card. And the 3%, it doesn't take very much. For some people, that's only $600. And it's easy for them to spend $600 on their meds. I love this quote about community health workers because you do have an opportunity to sit, be present with someone, understand their situation, be able to relate that information to their providers, help improve the quality of their life, their health care, and it's that really honest dialogue that's changing things. So I want to thank you all for listening to me. Thank you for the work that you do with patients. I'd be happy to answer questions.
Question. You were going through the donut hole and tier 3, tier 1, and so on and so forth. Do you have a good resource where we could go to log on to kind of just review that, like maybe where you pull back a bit?
So we've done several presentations to patients on this, and so I do have a couple of slide presentations where I could send you slides that you can then go through kind of the steps of it. It's in language for patients that would help. Would that work?
Medicare.gov is a wonderful resource. We use it with Shiva.
There you go.
And it has an explanation for patients on Part D that's real easy to print out and show.
Thank you. Yeah, I think there's a lot of resources out there. All right, anything else?
Thank you.
Yeah, you're welcome. Thank you.